Hi everyone, we are back with our second presenters of the day. I'd like to introduce you to Abigail O'Connell. She's here from Roper St. Francis Healthcare down in Charleston, South Carolina. So she had a little bit of a drive today
it was
or yesterday?
uneventful. It was, I drove up this morning, but it was smooth sailing.
Good.
So no complaints.
That's always good, 26 when you're smooth sailing. That's what you want.
That's the best you can ask for.
Well, so you just presented to our crowd in the next room, and you guys have some trials going on down in Charleston. So would you tell us, just sort of broadly speaking, what was your presentation about today?
Yeah, so basically I gave an overview of all of the clinical trials that we're offering right now. And essentially I think the key takeaway would be that really no matter what point in time it is, we have clinical trials that run the gamut from prevention of Alzheimer's disease, so identifying participants that have particular risk factors that put them at higher risk for developing cognitive decline, even though they're normal, as we say, cognitively normal right now. And then also looking at patients with mild cognitive impairment, so also at higher risk for Alzheimer's disease because they have some mild cognitive changes, but they are measurable and they're above what we would consider normal aging, right? Okay. And then we also have clinical trials that are looking at patients with Alzheimer's disease, not only disease-modifying treatments where we're looking at changing the course of the disease, so slowing down the progression, but also other therapies particularly geared at patients with moderate Alzheimer's disease, looking at addressing symptoms like agitation or apathy. We know that for patients and their caregivers of patients with these symptoms like agitation, they can be hugely disruptive in terms of day-to-day life. We don't have effective therapies at this time. We don't really have good therapies that don't carry a high side effect burden and really reduce and really increase the risk of injuries, falls, things like that. So if we can find effective treatments for these symptoms, it can make a real improvement in terms of that patient's and their family's day-to-day life. So really at any given time we try to have a full range of studies so that no one is feeling left out, right? I think we as researchers get really excited about prevention trials, but the problem is that for our patients that already have Alzheimer's, they say, well, what about me, right? It's too late for prevention for me. And so I think it's important that we always maintain a portfolio of clinical trials for patients that already have the disease, trying to figure out how we can better meet their needs, address their symptoms, prevent progression. And so we're always working on that as well. And that's really important to us.
That's great to hear. So this next question then is probably going to feel like I'm asking you to name your favorite child. But since there are so many studies that you have going on, is there one that you are most excited about that you think is maybe a new idea or something that is really promising that we haven't heard much about yet?
Yeah. So I do get really excited about the Alzheimer's prevention trials, of course, because if you're talking about preventing Alzheimer's disease, that's both extremely exciting and it's really sexy, right? And we all as researchers get really excited about that. I'm also really interested. So one of the studies that we're doing is run by a company called Intracellular Therapeutics, ITI, and it's a novel molecule that's aimed at treating agitation in Alzheimer's disease. They're also looking at this molecule in other disorders like schizophrenia or major depressive disorder. So the interesting thing about this molecule is it seems to work on a couple of different neuronal pathways, and the indications, at least from the earlier trials, are that it's effective in facilitating restful sleep at night, which we know is a huge problem in the Alzheimer's population, and also is diminishing agitation and aggression, right? So it's working on serotonin pathways. It's working, as on a number of different levels in terms of neuromodulation without that side effect profile. So it's not a sedative medication, which a lot of our traditional kind of approaches to agitation are. And I think that if this is an effective therapy, it just really can impact the day-to-day life of these patients, because these are patients and caregivers that we see every day, and the impact of agitation is devastating for these families. And that's one thing that we talk about. One of the things that's so difficult about Alzheimer's is you lose the loved one twice. right? And when you throw agitation in the mix there, it's even harder, right? Because this is just a different person. And I think that seeing some hope there just is really motivating to me to meet these needs.
That's really
of these
exciting
patients.
to hear.
Yeah, absolutely. And I think it's time. I think I don't think that necessarily historically we have given a lot of time to these kind of symptoms. We just, for a long time historically, it was like, well, apathy, this lack of motivation, that's just part of Alzheimer's disease. Or agitation, well, some people get it, some people don't, right? And we haven't necessarily spent a whole lot of time or effort or money in order to figuring out how to effectively treat this. And so I think it's exciting that we're paying more attention to this as its own discrete symptom and offering some hope to those families that are suffering with these side effects.
That's really important work.
Yeah.
I'm very interested to hear about that because I know that's what many caregivers, that's what brings them to the end of their rope.
Absolutely.
So that's really important.
And it is a huge component of caregiver burnout. I mean, all of these things that, the Alzheimer's Association has been instrumental in researching more in terms of the burden on caregivers and that's part of the expense of Alzheimer's disease, right? Is that's part of, it is the biggest driver of people having to put their loved ones into assisted living, which most caregivers don't want to do, right? I mean, everyone wants to live out their days at home, and every caregiver usually wants to live out their days at home with their spouse or with their father or mother. But when you're dealing with agitation that you don't have a solution for, it just forces your hand. You don't have the choice, and caregivers experience a lot of guilt because of that. I mean, there are so many effects on caregivers and families just aside from the patients. So I think it's such an important focus of our research. So I'm really excited to see what that trial brings.
That's cool.
Yeah.
Well, so the flip side of that coin, the prevention research, I know that's something that a lot of us are interested in, especially people who may have family history. That includes me.
Right.
So
me too.
It's really interesting to be like, okay, if there's something we can do to stop this, that would sort of be the holy grail, right?
Absolutely.
So you mentioned that you do have at least one trial going on. Can you tell us a little more about what's involved in that? Like who can be eligible for it, and what does it include? Does it include lifestyle risk factors, or is there an experimental treatment, or what are we talking about here?
Yeah, so the biggest prevention trial that we have going on right now is with the Novartis company. There's two kind of companion studies, Generation 1 and Generation 2. And what they're looking at specifically is the risk factor of being a carrier of the APOE4 gene. Okay. So there are probably hundreds of genes that are correlated with an increased risk of Alzheimer's, because certainly not everyone with Alzheimer's is a carrier of APOE4. Only about 50% of Alzheimer's patients have a copy of APOE4, but it is a gene that we know a lot about. And essentially having one copy of APOE4 increases your lifetime risk of cognitive decline, above what we consider normal aging to about 20%. Having two copies of APOE4 increases your risk to about 50%, which is pretty alarming, right? Most of us would rather not have those odds. And so the way that this study works is it's in Generation 1, it's just for people with two copies of APOE4. In Generation 2, you can have one copy of APOE4, but they also do a PET scan to identify if you already have elevated amyloid. So we consider that another risk factor, right? It's not definitive because there are plenty of 95-year-olds walking around with brains full of amyloid that are perfectly sharp, right? But we also know that having amyloid, if you have cognitive decline, means that that's Alzheimer's, right? It's a pathologic hallmark. So if you, and we also know, because we have this PET scan technology where we can see the amyloid, that people that go on to develop cognitive decline will already have those plaques for 20 years, right? Before they develop symptoms. Yeah, absolutely. And it definitely is something that we take into account because we're telling people that are normal, we can see this pathology in your brain, which is quite frightening, right? So there's a lot of counseling around that as well, and kind of what that means and what the risk percentages are that go with that. But the way that the Generation trial works is the very first step is super easy. You just do a cheek swab that identifies whether or not you're a carrier of APOE4. If you are a carrier, then you are eligible to proceed to a screening visit where we do, a whole bunch of assessments, both safety assessments and cognitive assessments, to validate that this person, yes, they are cognitively normal. And then there's, an MRI also for safety and a PET scan. So if you're a homozygote and you have 2 copies of APOE4, you don't need the results of the PET scan to get in. If you're a heterozygote, you only have 1 copy of APOE4, you do need that elevated amyloid, right? Yep. So it's the 2 risk factors, and that's in generation 2. And then if you choose to participate in the trial, it's a 5 to 8 year study.
Wow.
It's a significant period of time. But as I was explaining, if you take someone that has no memory problems and you're essentially saying, we think you're at higher risk for Alzheimer's, right? We've looked at, you have this gene, you have this PET scan, so we think you're at higher risk for Alzheimer's. Now we're gonna do tests and wait for you to get worse, right? Or if you're on the placebo, if you're on the control, we want to see if you don't get worse compared with people on the placebo. But you have to give that time to happen, right? Because if you're normal, you're probably not going to have measurable decline within a year, right? So the longer the trial is, the more chance you have to capture the differences between people that are on the drug versus people that are on the placebo. And they're testing the generation 2 study is testing a BACE inhibitor, which prevents the production of beta amyloid, so prevents those amyloid plaques from getting worse, right? The generation 1 study is also testing that drug in half of the study population, so they get that drug or the placebo. The other half is getting a placebo versus an amyloid immunotherapy, which actually takes the beta amyloid out of the brain, right? So removing the plaques that are already there versus reducing production of further plaques. And so either way, it's, can we take people that are normal? Can we find reliable risk factors that are going to predict that they have a higher risk of developing decline? And do either of these treatments work in preventing them from ever getting the disease, which of course would be the holy grail. And kind of looping back to what Dr. Fargo was saying, it's just like how we do cholesterol screenings, right? We no longer wait for someone to have a heart attack to do something about heart disease. We screen for cholesterol, we treat high cholesterol with statins, then we greatly reduce their chances of developing heart disease. So we're basically trying to step back and take the same approach to Alzheimer's disease, where here are reliable markers that we found that that predict you have an increased risk. Here's something we can do about it, and then you never get Alzheimer's, right? And that would be the holy grail.
That would be amazing.
That's what we want.
Well, I want to take one step back and just, if you haven't heard amyloid before, that's the protein that accumulates in brain cells, right, or around the brain cells,
around the brain
right?
cells, exactly.
And it's one of the hallmarks of the disease.
Exactly.
So when you look at the brain, that's one way that we know for sure that it was an Alzheimer's type dementia. So that's really important to the study, because we know we're treating this specific type of dementia. We're trying to, we're comparing apples to apples and not mixing in some oranges there. So that's why you're doing the scans and everything.
And if the point of the medication is to reduce beta amyloid plaques, you have to have them in order to do something about them. Just in the same way that your doctor wouldn't prescribe a statin without knowing that you have high cholesterol, because there's nothing to work on if you don't have high cholesterol. But it's also to establish this specific risk factor that we know is associated with Alzheimer's disease.
So if I'm watching this video today and I'm like, wow, that sounds really interesting, I might be willing to come to Charleston a few times over the course of 5 years. That wouldn't be a huge
And you
hardship.
only have to, and once patients are enrolled, they only come every 3 months. So while it is, 8 years is a super long time, who doesn't want a trip to Charleston 4 times a year?
Cool. Well, thanks for telling us about that. And if people want to learn more about that study and how to get involved, what's the easiest way for them to find more information?
Yeah, absolutely. So I would say the easiest way to get information about any of our trials, or just information on, are you a good candidate? Do you have any interest, or do you have any memory concerns? Is just to call us. So you can call our recruitment and patient outreach department at 843-724-2214, and they can give you more information and email you information if that's kind of the way that you like to communicate. But I would say that's the easiest place to start. start, so we can make sure that we're giving you the right information and information on what you're interested in, or specifically what's linked to your concerns.
Yeah, and as Dr. Fargo mentioned in our earlier interview, there are a lot of trials out there. There are some excellent ones down in Charleston, but if you want to kind of find out what all the ones are, maybe see if there are any closer to you, you can also visit alz.org and enroll in our trial match program. So that just includes creating a profile to let people know a little bit about you and what your interests are and how far you're willing to travel, which is an important consideration. And it'll let you know about trials that might be interesting and possibly a good fit for you. So it doesn't commit you to anything, but it definitely helps you stay in the loop and find out about those opportunities.
It's a great resource, and a lot of patients come to us through trial match because
glad to hear that.
They'll say, oh, we found your site, through trial match. And so we definitely, and we encourage people to go to the Alzheimer's Association website for really any kind of information about Alzheimer's and dementia. We tell our patients and our participants that it's such an amazing resource. There's so much information on there, but it's so easy to navigate. And I find that that our participants find it really an easy way to get information and get connected with exactly what they're looking for.
That's awesome to hear.
Yeah, absolutely.
Well, thank you so much for talking with us today, and thank you guys for watching. We'll be back again in a little while.